have uploaded the videos on previous topics. Now we will discuss the fetal emergencies, that is cord prolapse and the shoulder dystocia. So, what is cord prolapse? A cord presentation is defined as the presence of umbilical cord below the fetal presenting part when the membrane are intact. Cord prolapse is the presence of cord below the fetal presenting part when the membranes are ruptured. Now, the incidence of cord prolapse is 1:500 in the deliveries, and the etiology is that it occurs when the fetal presenting part does not fit well into the maternal pelvis, giving space for the cord to prolapse when the membranes are ruptured. Now, the risk factors for cord prolapse are maternal causes and fetal causes. The maternal causes are pelvic tumor, for example, fibroids in the lower segment and narrow pelvis or contracted pelvis, and the fetal causes are prematurity, malpresentation, for example, breast, transverse lie, polyhydramnios, and large baby. Now, the diagnosis for the presentation for the fetal emergencies are that first of all, vaginal examination is done. Cord may be seen in the cervical canal or vagina or speculum. Then cord pulsating may be felt digitally. Moderate to severe deceleration of the fetal heart due to compression of umbilical vein between presenting part and pelvis reduces the blood flow to the fetus. Now, fetal bradycardia is present, that is total cord compression for longer than 10 minutes will cause cerebral damage and continued for around 20 meters, and it can cause death. The management options are immediate management aims to minimize the pressure of the fetal presenting part on the cord while plans are made to deliver the baby. Maneuvers applied to minimize the pressure of fetal presenting part. Keep the presenting part continuously pushed upwards with examining finger to remove the pressure from the umbilical cord. Then placing the patient in semi-prone position, that is SIMS position, and fill the bladder with 500 to 700 ml of saline with Foley's catheter and maintain cord temperature. There should be minimal handling of the cord as this causes spasm, which will reduce the blood flow. Now, the delivery is done as an emergency C-section, which is required unless the cervix is fully dilated, and assisted vaginal delivery can be safe and easily performed. While making arrangements, the above maneuvers should be performed to prevent the cord compression, and inhalation should be done. So, we have discussed the topic fetal emergencies, and we have discussed the cord prolapse, in which we have discussed the incidence of the cord prolapse, then the causes of the cord prolapse, then we have discussed the risk factors, which are the maternal causes and the fetal causes. Then we discussed the diagnosis for the cord prolapse, which are vaginal examination and the fetal bradycardia is checked. Then we discussed the management and the maneuver for this defect, and then the delivery option. Now, coming towards the shoulder dystocia. As per Royal College of Obstetrician and Gynecologists, the need for additional obstetric maneuver to release the shoulders after gentle downward traction has failed. Okay, so the need for additional obstructed maneuver to release the shoulders after gentle downward traction has failed. After the delivery of head, the shoulders are arrested at the pelvic inlet and they require additional obstructed maneuver to relax and deliver. So this is shoulder dystocia. What happens that after the delivery of the head, the shoulders are arrested at the pelvic inlet and they require additional obstructed maneuver to relax and deliver. Now, the incidence of shoulder dystocia is 0.2 to 1.1%, and the mechanism for shoulder dystocia is during vaginal delivery. The fetal head and shoulder rotate to make use of the widest pelvic diameter, and after delivery of the head, the restitution occurs and the shoulder rotate into anteroposterior diameter. This makes use of the widest anteroposterior diameter of the pelvic outlet. However, if the shoulder have not entered the pelvic inlet, the interior shoulder may become curved above symphysis pubis. Occasionally, both shoulders may remain above the pelvic brim. So, this is the mechanism of the shoulder dystocia. Then the diagnosis is usually obvious when the shoulder failed to deliver during the next contraction after delivery. It called the turtle signs, which is the appearing of head that pulled back to perineum at delivery. Okay, so it's usually obvious when the shoulder failed to deliver during the next contraction after delivery of the head. It is called the turtle sign, which is appearing of the head that is pulled back to the perineum of the delivery. The risk factors are maternal, the fetal, and the intrapartum. Maternal risk factors are diabetes, short stature, previous history of the shoulder dystocia, and obesity. The fetal risk factors are macrosomia, post-maturity or post-death pregnancy. And the intrapartum are long first stage of labor, long second stage of labor, instrumental delivery, induction of labor, and the use of oxytocin. Now, the complications are both maternal and fetal complications. The maternal complications are risk of perineal tears, uterine ruptures, uterine atony, PPH, extension of the injury, and to lower genital tract, that is vagina or cervix. The fetal complications are risk of the birth asphyxia, neurological damage due to damage to the brachial plexus, skeletal injury to the fracture, etc. Now, the management options are different maneuvers. That is, initial maneuver is call for help, that is, midwife and experienced obstetrician. Then, ensure the personnel are available to scribe and documentation the tune of the head of delivery is anterior and the time at which each maneuver is applied. Drop the bed level at the time of delivery as low as it will go and flatten the back of the bed so the woman is completely flat. Assess for and perform episiotomy. McRoberts maneuver is applied, which is flex and abduct the mother's legs at hip and flatten the lumbosacral spine and facilitate delivery. Okay, now the second line maneuver is best carried out by anesthesia. It is suprapubic pressure by another assistant and the delivery of the posterior arm by pushing a hand into vagina and pulling the posterior arm of the fetus. Then the delivery of the interior arm by pulling it across to the chest. Internal maneuver is applied if these fails, then internal maneuver are necessary. Robin's 2 maneuver, wood screw maneuver, reverse wood screw maneuver. Then the third line maneuver is destructive procedure. Cledotomy, deliberate fractures of fetal clavicles to reduce the bicranial diameters, and physiotomy, maternal surfaces is divided, and zeranellis, in which head is reduced back to vagina, and C-section is done after the delivery of the baby. Risk of maternal morbidity should be remembered, prevent PPH and check for vaginal trauma. And next, pregnancy, briefly the woman and suggest the C-section. So we have discussed the topic, the shoulder dystocia, in which we discuss that it is the delivery of the head. After the delivery of the head, the shoulders are arrested at the pelvic inlet and they require additional obstructive maneuvers to release and deliver. So this is shoulder dystocia and this is the incidence of the shoulder dystocia. This is the mechanism. And the diagnosis of the shoulder dystocia is obvious when the shoulders fail to deliver during the next contractions of the delivery of the head. The risk factors for shoulder dystocia are maternal risk factors, fetal risk factors, and intrapartum risk factors. Then we discuss the complications of the shoulder dystocia, which are both maternal and fetal. Then we discuss the management options, which are different maneuvers. First of all, initial maneuver is applied. Then the second line maneuver is applied, and it is best carried out by general anesthesia. Then the internal maneuver is applied. If these fails, then internal maneuver are necessary. That is Robin's 2 maneuver, wood screw maneuver, and reverse wood screw maneuver. Then the third line maneuver is applied, which is a destructive procedure. And it is cledotomy, symphysiotomy, zeranellis, and C-section. And for next pregnancy, briefly the woman and she is suggested for C-section. Okay, now the next section is the fetal distress, in which we are having a scenario that okay, now the next topic is fetal distress. So we are having a scenario that how to detect the fetal distress in first stage of labor, and another scenario is that fetal distress is diagnosed by PNAD and meconium strand ligature at 6 cm cervix dilatation is present. So what are the options to confirm the fetal distress and what are the management options? So we are having the definition for fetal distress is that compromise of the fetus during the antepartum period or intrapartum period. It is the term that is commonly used to describe fetal hypoxia, which can result in fetal damage or death if not reversed or if the fetus is not promptly delivered. It also refers to the presence of signs in a pregnant woman before or during childbirth that suggest that fetus may not be well. Okay, so we have discussed the definition of the fetal distress, that it is the compromise of the fetus during the antepartum period or intrapartum period. Then it is a term that is commonly used to describe fetal hypoxia, which can result in fetal damage or death if not reversed or if the fetus is not promptly delivered. It also refers to the presence of signs in a pregnant woman before or during childbirth that suggest that fetus may not be well. Now, the causes of the fetal distress are maternal illness and fetal illness. The maternal illness are anemia, placental abruption, cord prolapse, fetal infection, abnormal position of the mother, gestational diabetes, eclampsia, preeclampsia, and uterine rupture. The fetal illnesses are cephalopelvic disproportion, shoulder dystocia, breathing problems, multiple births, abnormal position, and umbilical cord compression. Now, the risk factors are, it includes the following: the woman with history of stillbirth, intrauterine growth resuscitation, postpartum pregnancy, oligohydramnias or polyhydramnias, RH sensitization and preeclampsia, hypertension, obesity, smoking, diabetes, and other chronic diseases. The signs and symptoms in mother are high BP, vaginal bleeding, cramping, weight gain of more than 40 pounds, and decreased fetal movement. In fetus, decreased movement of the fetus, meconium in the amniotic fluid that is dark green, and oligohydramnias. On CTG, fetal bradycardia or tachycardia, especially during and after contraction, is present. Decreased variability in the fetal heart rate and late deaccelerations. The fetal scalp blood sampling agent, which is fetal metabolic acidosis, pH less than 7.2, and increased levels of the fetal blood lactate and abnormal slowing of the labor. The diagnosis is CTG, fetal heart rate monitoring, low biophysical profile score, umbilical artery Doppler ultrasound showing increased placental vascular resistance, and ultrasound which shows IUGR, that is intrauterine growth resuscitation in macrosomia, amniotic fluid assessment, that is oligohydramnias. Okay, now the treatment options for fetal distress is that intrauterine resuscitation is done, that is changing the mother's position, left lateral position, ensuring mother and keeping her well hydrated. Then intravenous infusion of ringer lactate or normal saline. One second. Okay, so these are the risk factors which include the woman with history of stillbirth and hypertension, diabetes, smoking, and other chronic disease. The signs and symptoms in mother are that high BP, vaginal bleeding, cramping, weight gain of more than 40 pounds, and decreased fetal movement is present. And in fetus, the signs are decreased movement of the fetus, the meconium in the amniotic fluid, which is dark green, and oligohydramnias. On CTG, fetal bradycardia or tachycardia, especially during and after contraction, and decreased variability in the fetal heart rate, late deaccelerations. The fetal scalp blood sampling shows fetal metabolic acidosis, pH less than 7.2, increased levels of the fetal blood lactate, and abnormal slowing of the labor. On diagnosis, CTG, fetal heart rate monitoring, low biophysical profile, umbilical artery Doppler ultrasound showing increased placental vascular resistance, and ultrasound which is intrauterine growth resuscitation in microsomia, and amniotic fluid assessment which is oligohydramnias. Now the treatment options are intrauterine resuscitation, that is changes mother position, left lateral position, ensuring mother and keeping her well hydrated. Then intravenous infusions of the ringer lactate or normal saline, adequate O2 amnio infusion, that is the insertion of fluid into the amniotic cavity to elevate the compression of the umbilical cord. Then tocolysis is then a therapy to delay preterm labor by temporarily stopping the contractions. Intravenous hypertonic dextrose is given, that is the treatment that underlines the cause accordingly, and hypertension, diabetes, preeclampsia, and eclampsia, and anemia. Emergency C-section is done, and the complications are cerebral palsy, birth injuries, more prone to infections, and mental retardation and developmental delays. So we have discussed the topic the fetal distress, and we have discussed the definition that what is fetal distress. It is the compromise of the fetus during the antepartum period or intrapartum period, and it is a term that is commonly used to describe the fetal hypoxia which can result in fetal damage or death if not reversed or if the fetus is not properly delivered. Then we discuss the causes of the fetal distress, which are both maternal causes and fetal causes. Then we discuss that what are the risk factors for the fetal distress and the signs and symptoms in the mother and in the fetus. Then how the diagnosis is done? It is done by CTG, by fetal heart rate monitoring, by physical profile, umbilical artery Doppler ultrasound, placental vascular resistance ultrasound is intrauterine growth resuscitation, macrosomia, and amniotic fluid assessment. The treatment options are intrauterine resuscitation and emergency C-section, and then we will discuss the complications which are cerebral palsy, birth injuries, mental retardation, more prone to infections, and developmental delays.